community outreach and research at the Simmons Cancer Center, working closely with our director, Dr. Arteaga, to promote cancer health equity within Dallas and Fort Worth and the surrounding counties. Please help me welcome Dr. Jasmin.
Good morning. Thank you so much for inviting me. It's a pleasure to meet all of you, and thank you, Keith, for the very kind introduction. So I'm here today to talk to you about why cancer prevention requires community engagement. And really it's one about a new initiative that our Simmons Cancer Center is doing in terms of forming our Office of Community Outreach Engagement and Equity. In part because our Simmons Cancer Center is committed towards improving the cancer burden across our DFW metropolitan statistical area, which is shown here on your right-hand side. You know, population distribution is very concentrated in our urban areas. So a lot of our efforts are focused in Dallas at our main site, as well as through Moncrief to reach the populations in Fort Worth. And then also thinking through what are the best ways to reach populations in our, what we call fringe metro area, the kind of the area surrounding, as well as our rapidly growing population north of our urban areas. Oops, wrong way. So being an NCI designated comprehensive cancer center means that we care about the full continuum of care. It's not just about treatment, okay? And this is what Dr. Reddy was talking about, how we're improving breast cancer treatment. But it's also about everything along that full continuum, taking care of people after they successfully combat cancer and are in the survivorship space. But also, you know, how are we improving the ways in which we prevent cancer and how we identify people at higher risk who would benefit from better surveillance and monitoring, as well as how we screen and detect cancer. And so one of the things that we do is we monitor in our DFW catchment area how we're doing in preventing cancer and the things that are recommended to us. We look at the U.S. Healthy People 2020 goal, and we compare how we're doing using the behavioral risk factor surveillance system, how we're doing in our western counties and Fort Worth and our eastern counties on these various markers of what we should be doing, right? So it's in red, smoking, because we shouldn't be doing that, right? And what we see is higher rates of smoking in our western counties. This rate is the adult rate, and what it doesn't show you is the fact that if you focus on our teen population, e-cigarette use is on the rise. And the most latest estimates are that 1 in 4, or 27% of our teens are using e-cigarettes and vaping. And you know, you don't have to be reading the news all that often to hear about the lung injury that is happening with e-cigarettes and vaping. And so that's something that we're really concerned about, right? So we need to focus not just on our adult population, but on our adolescent population. We can do better, this is also showing you, in terms of uptake of breast, cervical, and colorectal cancer screening, where we see lower rates than what our national goals are across the country, and that's why we have programs like those that Keith was mentioning earlier in screening to improve that. Of course, we can also do better in physical activity. We're not hitting our marks in terms of physical activity of 150 breaks. And then finally, the work where I research is in adolescent HPV vaccination. And in North Texas, we are doing much worse in comparison to the rest of the country. The rest of the country is over 50%, 50 to 55%, and we have lower rates of HPV vaccination. Understanding why this is happening is really important because otherwise we're not doing a good job in our cancer center. So, you know, what we do and what we're studying is really what people were talking, and Dr. Arteaga was talking about earlier, in terms of translational research continuum, okay? So we cover things from discovery to delivery, and we start by understanding the mechanisms of disease. And this is an illustration of the HPV vaccine, the HPV virus, right? And so in the 1980s, we discovered that a virus can cause cancer, and that it actually causes 6 different cancers of the cervix, oropharynx, the head and neck, throat, anus, penis, vagina, and the vulva, okay? And what we discovered is that this is a ubiquitous infection. It's a very common infection, and most people have a very successful immune system that can combat that infection. But unfortunately, some, when in their late 20s and early 30s, can't fight that infection, and it becomes persistent, and that persistent infection causes precancer cells to develop and grow and metastasize. What we then discovered, and this is the current head, Dr. Lowy of the National Cancer Institute, and his collaborator, Dr. Schiller, is that we can actually identify and create virus-like proteins, these proteins that sit on the outside of your cells to trigger your immune response. So they developed a preventive vaccine, not a therapeutic vaccine, not after you have the disease, but a preventive vaccine to trigger your immune response by exposing you to the virus-like proteins that sit on the outside, and they developed a vaccine for it. And then they tested that through a clinical trial where they randomized some to receive the vaccine and some to receive the placebo vaccine. And then they looked at them over time, and they showed that those that received the true vaccine had no development of those precancerous cells. And as a result of that clinical trial, in 2006, so about 13 years ago, the FDA approved the vaccine, and our CDC, the Advisory Committee on Immunization Practices, recommended this vaccine. It started as a 3-dose series, recommended 11 to 12 girls, and then in 2011 we had acquired the evidence to show that it was also beneficial to boys, and so it was recommended for both. This whole pathway is the success of a cancer center and a comprehensive cancer center. And I was at the National Cancer Institute when this FDA approval came through. And all of the basic scientists and all the epidemiologists said, okay, our job is done. We figured out how to combat 6 different cancers. We can focus on other things. And my perspective as a behavioral scientist and a public health scientist was, oh, that's really cute. Our job isn't done. Why isn't our job done? Because if our job was done, then I would exercise every day, okay? Because we don't always do what we think we're supposed to do, what we're told to do, okay? Knowing doesn't mean it translates into behavior. And so what we see is, and we can talk about it in funny cartoons or in Field of Dreams, but just because you've built it, just because you've made this important cancer prevention discovery, doesn't mean people take it up. And so that's where the work that we do on the dissemination and delivery phase happens. Because what we see in studying the delivery of cancer care is that it takes 17 years on average for all of our discoveries, all of our research to translate into actual clinical practice. And unfortunately, it translates unequally across the United States. So about 50% of Americans receive actually recommended clinical care, and when they don't receive recommended clinical care, we have disparities that happen in cancer outcomes, and we see unequal, non-timely delivery, okay? So this is the research that I'm interested in focusing on and understanding. Why is it so hard in this day and age to get people to do what are the recommended vaccines? One of the things that we've been studying a lot recently, the internet's an amazing thing. It truly is an amazing thing. It's an amazing thing that has some negative backlash. And we see that through social media. Social media in terms of the spread of misinformation. So I think it's very hard now, as a mother of a 13-year-old and a 10-year-old, to deal with this deluge of information and the different information that we see. And what we actually see is that sometimes what's happening in the internet is being used against us and doing things where and it's a really fascinating modifier. How can we weaponize health communication and basically cause doubt for something that we know and have shown through research to be very good for our population? And we see ads like this one that drive me absolutely insane that say vaccination is a gateway to IV drug use, okay? I mean, it's just inflammatory, okay? It's just inflammatory, okay? And as a result of that, it also causes doubt and causes an adversarial relationship between our doctors and the patients and parents, right? And so you see this book, it's How to Raise a Healthy Child in Spite of Your Doctor. When did we become adversaries of each other as opposed to collaborators and working to protect our children's health. Things that we need to study and understand. As a result of that adversarial relationship, as a result of this social media misinformation, we see a lot of heterogeneity 13 years out in terms of HPV vaccine uptake. So lighter colors here are states with lower rates of vaccination, and I showed you earlier what was happening in DFW. Texas has one of the lowest rates across the country, higher rates up in the Northeast and on the West Coast side. So one of the things that I focus on in my research is this idea of HPV vaccine hesitancy. What is hesitancy? So it's a continuum of how people are reacting when they get offered a vaccine. We know that there are about 2 to 5% of parents who always refuse all vaccines. That's what we call our hardcore anti-vaxxers, okay? But the majority of people are vaccine hesitant. They refuse, but they're unsure. They accept, but they're unsure about their decision. And this population is actually growing because of the social media misinformation. And it's not because, you know, it's really because we're causing doubt, okay? And we're not doing an effective job educating and reaching out to parents. And so my research is really focused on how can we improve parent-provider communication, recognizing that this is a partnership working together, that the providers need to be prepared and proactive in explaining and educating. And this is not just your doctor, but also your provider team, the way in which your nurses and everyone else in the clinic is helping in this process. And then also how parents are informed and motivated to work on that. Because having that communication be positive and be effective, we can enable informed decision making, we can improve motivation, and from my perspective, we can get uptake of the HPV vaccine, which is a very good thing. Okay, how do we do that? How can we do that more effectively? So as a behavioral interventionist, I develop interventions that understand how we can send messages, how we can communicate with the public in more effective ways. One of the ways that we've been studying is through a self-persuasion strategy. And really, it's something that can generalize not just to HPV vaccination, but how you treat and interact and make healthcare decisions in general. How do we engage people so that they can take in information, receive it, and understand, and then act on that? In the past, my colleague at SMU was studying whether we can get them to write their reasons for getting a particular behavior. And one of the things I'm interested in is that's kind of hard to do for a lot of people who aren't highly literate. Can we get the same effect if we have them verbalize their reasons via an app? They can learn information and then test that. And we can test the reason why it's effective by cognitive processing. Is it deeper thinking about the content and the information? Or is it because they're getting to choose the topic? And we tested that with a randomized controlled design. So we can use that both for drugs and we can also use that for behavioral interventions. So we've developed an app called Project Voice, voicing your thoughts about the HPV vaccine. And what we did was first we asked parents to watch a 4-minute video so they could have basic information about the HPV vaccine. We asked them after watching that video what their thoughts were about the vaccine. We then randomized them to show and operationalize different parts of the self-persuasion mechanism. So first, some in the groups that were given choice were asked to choose a topic that they wanted to think more about, and there were 6 topics here that you can see on the right-hand side. Then those in the verbalize condition were asked to generate their thoughts, and so what they would do is they were asked a question, and then they clicked on that button and they recorded their answer, and that showed their kind of cognitive engagement in the topic, and they were asked to summarize their reason. We compared that to groups who were either assigned the topics, 3 topics to brainstorm about, or they listened to topics that were generated based on other parents' reasons, right? So is choice of the topic affecting and influencing their reaction and their engagement, or is it their verbalization versus listening? And what we see is that just by watching the 4-minute video, we convinced 32% of parents to vaccinate after just watching that video. So they just needed basic information and they were ready to move on. For those that were randomized to the self-persuasion condition and moved on, we then saw that those that verbalized their reasons, spent that time thinking and engaging, another third of them decided to get the HPV vaccine, and we saw lower rates of deciding if they just listened to reasons, right, as opposed to being actively engaged. And then we looked at also over 1 year whether the app increased actual adolescent vaccine uptake. And what we see was a difference, right? And so we didn't actually see higher vaccine uptake in these two groups, and that was disappointing. But why is that? We delivered the app outside of a clinical setting, okay? And as a mother of a 13 and a 10-year-old, how easy is it to get your kids into the doctor, schedule the appointment, drive down there, et cetera, do it around the school visits and stuff like that. And it's really about, and that's where we're talking about action planning, okay? How can we help them do action planning? So in the next phase of our study, we've developed, with support from Lyda Hill, a 2.0 version of our app. This is a poster that we have available in clinics that show how parents can download the app. And we've added that action planning component which is the reason why we think that app wasn't as effective. It changed people's intentions, it changed people's decisions, but it didn't necessarily change their behavior. And that's what we're testing on that. We also enabled parents to report for the 1/3 that remained who didn't decide to get the vaccine after being exposed to the app. They still had some concerns. And what we were able to do was change the format of the app so they could report their vaccine concerns and get a printout and share that with their doctor, right? So we can help and improve the parent-provider communication. So that's an example of how people in our population science cancer prevention group develop research to then bring it out into the population. And researchers in population science then transfer that discovery of interventions to our office. And what we've been doing is getting those discoveries, those research discoveries of how to engage in those behavioral interventions with Cancer Prevention Research Institute of Texas funds, and Moncrief is a great example of where we've been leveraging these great funds through CPRIT, $32 million that we've secured through UT Southwestern to help make sure that we optimize the reach of our interventions to underserved populations across our catchment area, as well as expanding our media presence to address cancer misinformation. And just some examples beyond HPV vaccination of things that we've been doing. B-SPAN is the longest running program and really kind of the jewel in the crown of Moncrief. B-SPAN started over 9 years ago. And it started with the discovery that we have 254 counties in Texas, and we have a national program, the National Breast and Cervical Cancer Early Detection Program, that provides free access to breast and cervical cancer. But we only had less than half of the counties had a provider available to use those funds and deliver those services. Why is that? Well, how to get access to those funds required filling out a 121-page form, and our small providers in rural areas couldn't do that necessary paperwork. And so what Moncrief did was they created a virtual network that enabled, and it grew from 5 counties in our catchment area to now 35 counties across our catchment, as illustrated in this map, so that we've delivered over the past year over 9,000 screening and diagnostic procedures to a diverse group of population who are underinsured. And what you see is that as a result of it, we've detected just this past year 73 cancers. And not only have we detected those 73 cancers, we've detected cancers that are early stage when you have the best treatment options. Great success. We do the exact same thing in other cancer types. So here's the Stop HCC program. Keith mentioned earlier, hepatitis C, another virus, can cause liver cancer. Everyone who's a baby boomer, everyone born between 1965 and older, are recommended to get screening, right? We look for a chronic HPV and hepatitis C infection, and then we deliver treatment to those, and we've connected with pharmaceutical partners so that we can make sure that those who are uninsured can also receive that treatment. And what we've shown is that we've detected 3% of chronic infection and detected 1 cancer. Similarly, in Dallas, we've developed the Fit for All program. This evolved from National Cancer Institute funding, Prosper, where not all of them go into the doctor, right? And so sometimes we do outreach by mailing FIT kits, fecal immunochemical kits, to patients so that they can do colorectal cancer screening. And then if those FIT kits are positive, we bring them in for a diagnostic colonoscopy so that we can take and find and remove those polyps and prevent cancer, because we take out that precancer. And you see there kind of the success rate of the Fit for All program. And then finally, LSPAN, our lung cancer screening and tobacco cessation program. We discovered that lung cancer screening for those who smoke, pack years, decades of smoking, that they could do a better job if we exposed them to CT lung scans. Uptake of lung cancer screening is low, particularly in our rural areas where we have higher smoking rates. And so the LSPAN program you see here covers our western counties, where I talked to you earlier about how they have higher smoking rates, and beyond those western counties to deliver CT scans. And they detected this past year 37 abnormal scans and 1 cancer. So it's the way in which we work together across the whole continuum to make those research discoveries and then create those outreach programs where we're seeing the greatest impact across our population, so that people don't have to do the back end part of that cancer journey, and we can prevent it early. And with that, I just wanted to say thank you for inviting me and taking time.
Thank you for a great presentation. We're going to start with the question in the back, please.
Full disclosure, I work for UT Southwestern, so I can't advocate for anything, but I love the work that Dr. Tiro does, and I think she showcased how CPRIT funds are helping us keep our communities healthier. So just know that there's an election in November on the 5th that involves that, and I don't know if you all can talk any further about how CPRIT has benefited the work that you all are doing.
Absolutely. So CPRIT, the bond that happened 10 years ago, and at the time that CPRIT was being discussed, I was at the National Cancer Institute, and one of the reasons why I moved to Texas was because of Texas's investment and commitment towards cancer prevention and delivery and prevention. So CPRIT, it's up for question, right? What I can tell you is that we have been very successful. I think out of all of the institutions across the state of Texas, UT Southwestern and Moncrief Cancer Institute, particularly affecting the western counties, have been very successful in leveraging our CPRIT funds to increase the delivery of cancer prevention services and diagnostic treatment services across. And it is my hope that we continue to do that. We right now in our catchment area, we have 20% uninsured. Okay, that's 1 in 5 people, adults, in our catchment area do not have health insurance. And it's not because they don't want to have health insurance. They work a job that doesn't offer them employer-based health insurance, okay? Or, and that doesn't even include all those that are underinsured, right? Those that have insurance but don't have great insurance, right? It doesn't offer them the full benefits. And so people choose, unfortunately, have less access to cancer prevention and control as a result of their uninsurance or their underinsurance. And so it's programs like BSPAN and LSPAN that really kind of create that connection. And so I can't talk enough about how CPRIT has really enabled Simmons to do some of the great work, and Moncrief Cancer Institute to do great work.
I want to just echo what Jasmin said, and I would never tell you how to vote. It is Proposition 6 on next Tuesday's ballot.
Yes,
so.
and it's early voting right now.
And it's early voting right now. Yeah, Tony.
can you speak to why people are hesitant to receive this HPV vaccination in Texas? Have you learned about that through your research?
Yeah, so we've done an environmental scan to ask questions about it, and parents, you know, there's a really interesting development that's growing. We call it conspiracy beliefs. And it's really interesting to think about how conspiracy beliefs can work in positive ways and negative ways, right? So, and let me first talk about a positive way. The Truth Campaign, I don't know if you guys remember the Truth Campaign about teen smoking, happened in the early 2000s, right? And it basically talked about how tobacco companies engage and market specifically to adolescents, right? And the Truth Campaign was highlighting the conspiracy of those corporations in targeting adolescents. And we see that happening right now with the e-cigarettes, right? So the rise in e-cigarettes among teens is in part because e-cigarettes are flavored, and those flavors are targeted towards kids, and we can see exposure to those flavored ads correlated with a rise in teen cigarettes, right? So for me, I'd love to do an educational campaign to teens about the conspiracy of how these tobacco companies. But we also see where conspiracies work against us, where there's this idea that our physicians are in bed with pharmaceutical companies, and pharmaceutical companies are just trying to make a buck. And they're not really trying to develop great technologies. They're not trying to create new immunotherapies and bring those to market, because it takes a lot of money to bring a new treatment to market, to bring a new vaccine to market. That conspiracy theory is hampering people's willingness to listen to information, and so they doubt, right? And so if you just have just an ounce of doubt, it can cause hesitation, it can cause you not to do it. And unless you're interacting with a provider who has a strong communication, or you're exposed to good education through an app or other things, you can just be paralyzed, right? So we see a lot more decision paralysis among parents, because everyone has the best of intentions, right? You're here to protect your child's health, but if you see one thing that makes you doubt whether this thing is really good, and makes you think that it's not, that there is a debate when there is no debate, that's where hesitation creeps in, and that's what we have to address.
So one of your slides, you listed all of the different cancers that HPV is associated with. Can you talk about what's become now kind of the bimodal graph, if you will, of head and neck cancer?
Yeah.
Head and neck cancer, whenever I was going through medical school, was a cancer of older people, mainly smokers and drinkers, and now?
Yeah. So one of the cancers that's actually rising in our catchment area, 4% increase over the past 5 years, is head and neck cancers. And it's head and neck cancer not among the smokers and the drinkers, but those that are exposed to HPV. Why is there an increase in HPV exposure among men, and why aren't they able to combat it? Something that we're still studying. But we don't have to understand why, because we already have a prevention technique. We have the vaccine that can be offered to all the way. So it's really important not just for you to think about cervical cancer prevention with the HPV vaccine, but also prevention of cancers that affect boys, and get it for your sons when they're 11 to 12.
And that head and neck cancer is appearing much younger, and all of a sudden now in our cancer center, we're seeing it in men and women ages 20 and 30. And so I'm not going to go through all the gory details. I'll let you connect the dots. But even more important to get our women and men vaccinated. Time for one more question.
You can take it later on now. I understand too. You don't have to be just in the teens. I've heard
Correct.
up to 40 years old.
Correct, right. So they just revised the guidelines that if you weren't vaccinated at the recommended ages of 11 to 12, before it was catch-up recommendation was through 27, and then now just this past summer, they extended it up to 45, and they recommend that you talk with your doctor about whether it will benefit you. Now, the thing to understand is HPV is a virus that is ubiquitous. It's very common. Most people are exposed in their late teens, early 20s when they first become sexually active. And by sexually active, I mean any sexual contact, okay? Because HPV lives on your skin. It doesn't, it's not through true,
No gory details, we get it.
But the point of the matter is that you'll most likely be exposed early on when you first become sexually